you would see the EKG, because I am pretty sure you are well versed with the question stem and question patterns. Does that sound okay? We'll be trying to assess, we'll try to decode the EKGs more and less regarding the questions. We'll be focusing more about the EKGs. Is my voice okay? Hyderabad? Inaudible है? Inaudible लिखा है? Okay. Alright. So we'll move on to the question 5. A 62-year-old male presents with history of diabetes and hypertension due to intermittent palpitation since the last 7 days. It is associated with diaphoresis and respiratory distress. He has a past history of anterolateral MI 2 years back. Currently, he receives aspirin, clopidogrel, enalapril, metoprolol and spironolactone along with metformin. His temperature is 98, pulse is 90 per minute, BP is 120/90 and respiratory rate is 28 per minute. BMI is 23. During evaluation, the patient develops similar fluttering in the chest. EKG is shown. What is the management of choice? I hope the technical glitches are over. And what we are trying to answer is patient EKG is going to be shown for a patient who has coronary artery disease, and the patient is now has a history of anterolateral MI. So this is the EKG, and I want you to answer this EKG for me, because I believe if you have revised and reflected upon what we just read yesterday, you would be in a better position to answer this. So answer this with me. What is the axis of this EKG? Axis of this EKG. So Vishakhapatnam, is visible now? So if you look at it closely, these are negative deflections. This is going downwards. Everything is down. The up is less than the down. So all of these leads, the V5, the VF, and the one lead is a negative deflection. So Tirupati and Amritsar, I'm glad you got this. This is an extreme axis deviation. Lead 1 and lead AVF both are negative, and hence this is an extreme axis deviation. The rate is very high. It is almost, if you look very closely, the rate is even less than 2 boxes. When it is less than 2 boxes, it is higher than 150. So it's higher than 150, that means it becomes tachycardia. So the only condition we discussed, the only condition that we discussed which can have a left with an extreme axis and tachycardia is a ventricular tachycardia. Exactly. So this is how a ventricular tachycardia looks like. When you look at it closely, you see the QRS intervals is dilated. The QRS interval is widened. When it is more than 120 milliseconds, it is called as a wide QRS complex. When it is more than 120 milliseconds, it is called as a wide QRS complex. When you are considering the conduction of a fiber down the electric track, that is the normal conduction system, it is going to be very rapid. this conduction system here is going to be very rapid. When it is rapid, the QRS complex is a narrow complex. But when it goes haywards and it goes from here to here and then this way, that means when it goes through the muscles, it becomes very slow. When the contraction becomes slow, the conduction becomes slow. And this is called as a wide complex tachycardia. This condition is called as a wide complex. And if tachycardia is present, it would be called as a wide complex tachycardia. So here in this case, if you look at any of the QRS complex, it would be dilated. It would be more than one large box. One large box is estimated to be 200 milliseconds. So if it is more than one large box or even one large box, yes, Pune, it is the first slide. If it is the more than one large box, then it is a wide complex tachycardia. Okay. So the question is, what is the management of choice for such tachycardia? So when you have a tachycardia starting from the ventricles going upwards, you cannot use a atrial method. You cannot control the atria, you cannot control the AV node. So AV node dealing drugs, we will just cancel them out. Diltiazem, propranolol, vagal maneuver. All these things will act predominantly on the AV node, and hence we are not concerned with them. This is not the answer. Now you have three options: amiodarone, dofetilide and lignocaine. The drug of choice for ventricular tachycardia is amiodarone. Amiodarone, as we started our whole discussion discussing about amiodarone. The reason we did this was amiodarone is so frequently used. It is the drug of choice in almost all kinds of ventricular rhythms. It has various mechanisms of action. So the answer is amiodarone. Are you clear with this much? So when you are approaching tachycardia, I never said lidocaine was the drug of choice for ventricular arrhythmia. I said lidocaine is used in ventricular arrhythmia. There is a difference. I like to eat chicken biryani, but I don't eat chicken biryani every single day. I eat roti sabji every day. That is the difference, right? So there is a difference between can be used and drug of choice. Manipal. So when you have tachycardia, you see the RR interval and you see that it is 3 to 5 boxes is our normal. When it is less than 3 boxes, it is tachycardia. Right? Once you see tachycardia, the next thing that you have to see in any question of arrhythmia is stability. First, you see if the patient is stable or not. If the patient is not stable, you don't want to think ahead. You don't want to do anything more. You want to give him the shock. You want to cardiovert him or defibrillate him. Theoretically makes a difference. Practically is not different. You want to shock that person if he is unstable. If he is stable, then you look at the QRS complex. You have to look at the QRS complexes. If the QRS complex is narrow, This came to the ventricle via the conduction system. Simple and straightforward. If the QRS is narrow, it came through the conduction system. That means it is a supraventricular rhythm. So ventricular options are ruled out as soon as you see a narrow QRS complex. If you see a widened QRS complex, this can be two things. A widened QRS complex can be a ventricular rhythm and it can be an atrial rhythm also. What this means is, it can be that the ventricles from here started the rhythm, which is called as if this started the rhythm here, this is called as a ventricular tachycardia. The other thing that can happen that it started from the atria, but it came down from this tract. It came down directly into the muscles. It did not go through the conduction system. If it came down the muscles, the musculature, this can also result in a wide complex tachycardia. The only differentiating feature between a narrow complex and a wide complex is narrow complex traverses the conduction system. So how do you differentiate a supraventricular wide complex tachycardia from a ventricular tachycardia? The first thing I have already shown you, and you already know that. That is the axis. You see for the axis, and as soon as you are sure the axis is an extreme left axis, you would know that this is starting from the ventricles. But when you see that maybe the axis or you're not sure about it, you can see for something called as AV dissociation. What this means is the P waves are still present on the EKG, but the PQRS complexes are not present. More important than this is something called as a fusion and a capture beat. So more important is something called as a fusion or a capture beat. What do you mean by a fusion beat? What do you mean by a fusion beat is, see, AV dissociation means that the ventricle is contracting on its own and the atria is contracting on its own. It is seen in cases of ventricular tachycardia. What is happening here is when you have the atrial rhythm, okay, and you have the ventricles here, which is generating the ventricular rhythm. The only reason, I repeated this many times yesterday and I'm repeating it again today. The only reason why a rhythm predominates in the myocardium is because of its rate. Till the time the ventricular rate is more than the sinus rate, it will result in ruling that rhythm. So the ventricular rate should be above the sinus rate. So if this goes early here, only then can it overthrow the atrial rhythm. What can happen at times is this atrial rhythm and this ventricular rhythm meet halfway. They meet halfway. This halfway meeting is called This halfway is called a fusion beat. This halfway meeting is called a fusion beat. So what it would be when you're talking about a wide complex tachycardia, it would be a smaller tachycardia and then it would be followed by a normal rhythm. That means this is a normal beat, this is a VT wala beat, and this is the fusion beat. This is a fusion beat. Okay. What you need to know here is where is the fusion? See, what you need to know is how are we diagnosing a patient with ventricular tachycardia? That is all we are trying to establish here. Ventricular tachycardia, you very well know, it has wide QRS complex, extreme axis. Apart from that, I said there would be something called as a fusion and a capture beat. Unfortunately, my slides today, I don't think I have this picture. I will come back to this topic tomorrow again so that I can show you more pictures and help you understand what a fusion and a capture beat looks like. But the basic concept is wherever the atrial rhythm will hit the ventricular rhythm, that will result in a fusion beat. So whenever you talk about ventricular tachycardias, you might come across this term called as fusion beats. We'll get to it tomorrow again, or today if I get the photos of it. The theoretical part, IV amiodarone, lidocaine, sotalol, procainamide are all drugs which can be used in case of ventricular tachycardia. Lidocaine is less used, amiodarone is most commonly used. The clinical clues, the conditions which can result in tachycardia are previous myocardial infarction, ongoing myocarditis, and dyselectrolemias like hyperkalemia and hypocalcemia. These are the two conditions which can result in ventricular tachycardias. That is, any condition which decreases the stability of the heart will result in ventricular tachycardias. So these are the signs which are present in cases of ventricular tachycardia. Something called as a concordance in all the precordial leads means right leads equal to the left lead. That is, V1 is equal to V6. Their concordance is they appear normal. They appear similar to these leads. When you look at this EKG, you look at V6 and you look at V1. They look similar. Both of them are basically appearing this way. This is called as concordance between the leads. This is a sign of concordance. Are you clear with this? What all things do you want me to repeat? Just so I'll just cover what we have just discussed. When you're talking about tachycardias, what you're trying to say is the rate is more than 100. Once you have a rate more than 100, you need to know, is it atrial or is it ventricular? The best way an EKG can tell you is by the QRS duration. If the QRS is more than 120, it is called as wide complex tachycardia. And if it is less than 120, it is called as narrow complex tachycardia. Okay? Narrow complex tachycardias are always supraventricular. Supraventricular tachycardias are narrow complex most of the times. What this means is if there is a narrow complex, it has to be supraventricular. No ventricular tachycardia will ever be supraventricular. I hope this point is clear. Now, when you are talking about a wide complex tachycardia, it is more often than not a ventricular rhythm. That means the impulse is starting in the ventricles and it is headed upwards towards the atria. That is why it would be always associated with extreme axis. It is associated with extreme axis. And also it is associated with bizarre looking concordant QRS complexes. When you're talking about a wide complex tachycardia which is supraventricular, it would be normal axis and there would be non-concordant QRS in all of it, QRS complexes. Are you clear with this points? With the amount of points that I've said? Okay. So with this, I'll just repeat what the question had asked. The question said that the patient is presented to you with diaphoresis and respiratory distress. With diaphoresis and respiratory distress. The patient now presents to you with fluttering in the chest. What is the management of choice for such tachycardia is the question. This is the tachycardia which was present. It is a wide complex tachycardia with an extreme axis. When it has an extreme axis, we are pretty sure it is a ventricular tachycardia. Supraventricular can occasionally be, we'll get to that point. Hold your horses. The treatment of choice was amiodarone. Here is a question where the diagnosis is also provided. It says, what is the management of choice for such tachycardia? The patient is diagnosed with a supraventricular tachycardia with aberrancy. Patient is diagnosed with supraventricular tachycardia with aberrancy. This is the whole question is the same. I've just modified the diagnosis. The diagnosis part of it has been changed through PSVT with aberrancy. What is the management of choice for such tachycardia? Any idea? What do you mean by aberrancy is, here is your SA node and here comes your AV node. Why do you want the EKG? We have given you the diagnosis here. You have an SA node and the AV node, and then you have bundle of His. You have the right bundle and you have the left bundle. Okay, stay with me, please. Please pay attention to this. What I am saying. You have a left bundle and you have a right bundle. Okay. Your nerves, your electricity current comes down from the SA node to the AV node, and then it gets conducted across both the channels, and you finally have one contraction. Imagine that there is a second path which takes some of this current directly into the ventricle. There is a second path which takes some of this current directly into the ventricle. This will now result into a tachycardia, because your ventricle, the part which is here, this your ventricle is now getting stimulated by 1 and 2 rhythms. This condition is called as an accessory pathway. This is a concept of an accessory pathway. In such accessory pathway tachycardias, procainamide is the drug of choice. Procainamide, a class 1A antiarrhythmic drug, is the most effective in such cases. Okay? This is called an SVT with aberrancy. We'll deal with it step by step, gradually. When you're talking about supraventricular tachycardias, you are talking about a rhythm which is originating above the ventricles. Okay? You're talking about a rhythm which is starting here, coming here, and down you have the ventricles and going into the ventricles. This particular phenomena is called as a supraventricular tachycardia. If a supraventricular tachycardia, the only reason why a supraventricular tachycardia is prevented in normal individuals is because of the AV node. AV node is the gatekeeper. AV node will not allow some impulses to travel through to the ventricles. It will allow some impulses to travel through the ventricles. How does the AV node manifest on the EKG? It manifests via the PR interval. The PR interval. This is because of the AV node, and this is called as the nodal delay. Are you getting it? This is like the toll booth on your highways. On your highway, the toll naka that you have, where you have to pay the money so that you can go ahead, all of the traffic becomes slow on the toll booth. This is your AV node. Please remember this concept. AV node is the toll naka of the heart. It will restrict the atrial rhythms to enter the ventricle. It will only allow the appropriate impulses to enter. When you are talking about supraventricular tachycardias, and if the supraventricular tachycardia results in hyperactivated ventricles, that means this is also going very fast. and this is also going very fast. This condition can happen in two scenarios. Either the AV node is not functioning properly, the toll naka is not functioning. That means all the cars from the atria can enter the ventricle. One scenario. The other scenario is that there is an additional pathway which is connecting the two cities together, bypassing the toll naka, and that is called as an accessory pathway. These are the two main scenarios how a supraventricular tachycardia occurs. Okay. When we are talking about wide complex tachycardias, if a patient had underlying right bundle branch block, and he develops tachycardia, his QRS was already more than 120. So this would be wide complex tachycardia. May it be right bundle or may it be left bundle. So these are the other examples of when a supraventricular rhythm can result in a broad complex tachycardia. Is the point of PR interval and how the complexes are formed, wide and narrow complexes are formed on the EKG clear to everyone? I'm waiting for your response. RBBB will not result in SVT. SVT can happen in patients with a right bundle branch block, right? Even if they have a bundle branch block, there can be a supraventricular tachycardia, and that tachycardia will be conducted down and it would increase the rate of the ventricles. RBBB does not result in a supraventricular tachycardia. When you're talking about narrow complex and wide complex tachycardia, if a patient already had wide complex on his EKG with a normal rhythm, a normal rate, like due to a right bundle branch block or a left bundle branch block, and suddenly this patient develops tachycardia, then he'll have a wide complex tachycardia. It is very simple. Nehru Nagar. It is very simple, right? If you have wide complex tachycardia, if you have wide complexes normally because of a bundle branch block, you develop tachycardia over it, you'll always have a wide complex tachycardia. That does not mean it's a ventricular tachycardia. Can I move ahead? Okay. So we'll move on to the next question. A 62-year-old male, let's skip ahead of all these questions and just try and evaluate this EKG. First tell me what is the axis? The axis, the rate, the rhythm, and what do you see in this EKG? It is a very important concept in cardiology. Kakinada, no axis. Sorry, normal axis. Okay. Why do you say normal axis? Why don't you say right axis? What have you written under D? What have I written under D? Where D? So if you look at it, okay, so I'm not interested in the axis, but this is nowhere a positive lead one. This is a negative lead one, and this is a positive AVF. So this becomes a right axis deviation. What I'm interested to know is, what is the rate like? If you look at this, what is the rate like? 1 large box, 2, 3, 4, and this is the 5th large box. So the rate is normal. This is not bradycardia. It is less than 5 boxes. Less than 5 would be 60 and like 70. So that does not become brady. The negative deflection is more than the positive deflection in lead one. That is why it is negative. I hope you were not assessing on the basis of the T wave. When you look at this, what is the PR interval? What is the abnormalities that you see on this particular area, this area? Reduced. Excellent. You can see that this is the P wave here, this one. And P wave, and there is no actual PR interval here. Okay, it is basically that the P wave is at the footsteps of the QRS complex. The P wave is at the footsteps of the QRS complex. Before you answer this question, what is important is you understand this physiology. Once you understand this physiology, it becomes very easy. So you were correct. So the thing here is, when you have the SA and the AV and you have the conduction system, I'll give you 3 scenarios. One is a normal conduction where it starts here, goes to this area, comes down, and then it gets disseminated towards this. What this does is there is a P wave, there is a PR interval thanks to the AV node, and then there is a QRS complex, and then finally T wave. This is what happens in normal life, aam zindagi. Now we'll look at mentor zindagi. What happens here is, from the SA node, AV node, you have the bundle of his, and again you have the 2 bundles, the right bundle and the left bundle. As I said, that the AV node is the toll naka. AV node will result in the PR prolongation. When it reaches the AV node, there is a time delay. But what if it does not have to reach the AV node at all? What if it can go into the ventricles directly? So it comes here, but there is one more track here which goes into the ventricles. This additional track takes the conduction with it. What happens now is there was a P wave thanks to this, and there is no delay in the QRS starting, because the delay which was caused by AV node is not there. As soon as the P wave starts, you have a QRS complex. Did you get the point why the PR interval is shortened? because there is no AV nodal delay. In reality, what happens is, when there is conduction down this path, say 100 joules, this conduction down the accessory pathway would be 30 joules, and that down the AV node will be 70 joules. Now, what we are trying to say is, down the 100 joules, 30 joules would go down the accessory pathway and 70 joules will go down the main flowing path. What happens because of this? This 30 reaches early. And when the wave of depolarization reaches the myocardium, what does it do? It depolarizes the myocardium. So this depolarizes the myocardium. And later, upon this myocardium, will your 70 joules come because of the AV delay. This comes later because of the AV delay. The whole point of all this is, this results in this wave here, which is called the delta wave. The delta wave. This delta wave is because of ventricular pre-excitation. Ventricular pre-excitation results in the delta wave. Is it clear? So when you see an EKG like this, you see a delta wave and you see the PR sitting at the footsteps of the QRS complex. You think about an accessory pathway. And as soon as you think accessory pathway, you have the answer. It is Wolff-Parkinson-White syndrome. Did you get the point I was talking about? I don't understand your question. Kolkata. If you're saying that the P waves are so close, that is what I have been all shouting about. The P waves are so close that the P waves are not overlapping on the QRS complex. If P wave is inside the QRS complex, nothing would be seen. Yeah, lead to. Pre-excitation is because of the early entry from the atria into the ventricles via the accessory pathway. See, the AV nodal delay is a normal thing. So AV node will result in the delay. This here is the P wave. Here, this is the P wave. This is the delta wave. This is the most probably, this is because of the paper is being folded here. That is why it appears like this. All the leads are not properly there. See, the whole of the musculature will not be refractory during that time. That is the exact point that you are talking about. That it will go through the different muscles. So some of the muscles will be excited and that will result in a delta wave. Tirupati, excellent point. So this fiber is entering the ventricle, which is a slow conductor. Is it clear now? See, the depolarization from 70 joules is going to reach the heart earlier than the 30 joules from the accessory pathway. The complete myocardium. It is 30 joules entered the ventricular musculature. The ventricle musculature, the 30 joules has entered, because of which it is now leading to a pre-excitation front. But that conduction is very slowly conducting. If these conduction fibers conduct at 10 meter per second, the ventricles conduct at say 0.1 meter per second. This is 100 times faster. So after the AV nodal delay, it will go 100 times faster into the myocardium. Is it clear? So the question is, what is the most likely cause of his symptoms? Correct. So it is the accessory pathway. So Wolff-Parkinson-White syndrome, it's basically the presence of an accessory conduction bundle. It predisposes to tachycardia. What I want you to remember is the treatment. You need to avoid adenosine and verapamil. Anything that blocks your check naka, if you block this pathway here, all this 100 will go down the accessory pathway. If you block this AV node, everything will go down. Everything will go down the accessory pathway, all 100 joules. So never give AV nodal blocking agents to these patients. You should never give AV nodal blocking agent. You do not want every current to go through the accessory bundle. So procainamide, amiodarone, flecainide and sotalol are the more commonly used drugs of choice. Are you clear with this much? Now we'll be talking about two conduction terminologies, which if you think about, it's very basic. What this means is, in cases of orthodromic conduction, what happens is, when you have the SA node, the AV node, and here you have the AP, that is accessory pathway, and then you have your bundle of His, followed by your Purkinje and your bundles. The drug of choice there is procainamide. We just talked about it. In a normal conducting system, it should reach the AV node faster. I didn't get your question. You'll have to reframe that question. Procainamide reduces wide complex tachycardia. So is it that it is superimposed on RBBB? Where is RBBB coming from? Okay. I think only the color red is visible. It controls, it decreases the activation of the accessory pathway. That's why it is used, procainamide. What I was talking about here, in a normal conduction system, the electricity will go down the AV node and it will enter the ventricles, and from the ventricles it will enter inside the accessory pathway. Sotalol is a class 3 inhibitor and that's why it is used. Sotalol has both type 2, class 2 and as well as class 3 properties. So it's because of its class 3 properties, that is potassium channel blockage, it can be used. Is it clear? So rather than going a lot, so we are not talking about orthodromic and antidromic conduction. What I was trying to tell you is, once you go, see, the thing is, if some channel follows the normal pathway, that is, it goes from the SA to the AV node into the ventricles, it will result in narrow complex tachycardia. What you mean by ortho is straight. Ortho means straight. So orthodromic conduction will have a straight, like a normal conduction, and it will result in narrow complex tachycardia. When you have an antidromic conduction means opposite, ulta. What that means is, it starts from the SA node and it goes to the AP. It goes to the AP, that is the accessory pathway, and from the accessory pathway it comes up to the AV node. This becomes an ulta conduction. So this will keep on conducting and this will keep on going round and round. This is called as antidromic conduction and it has wide complex tachycardia. Not very important to understand. What you need to understand is, supraventricular tachycardias can have both narrow as well as wide complex tachycardias. When they have wide complex tachycardias, always think of accessory pathway as an associated problem. I want you to solve this EKG. This EKG can be asked in your exams. Yes, in orthodromic conduction from our ventricles to the AP. Please focus on this question and try and answer this question. Try and tell me the rate and the rhythm. So it is a right axis deviation, that's correct. Can you see the tachycardia? It is narrow complex tachycardia. Excellent answer. So this is an example of a narrow complex tachycardia. Whenever you see a narrow complex tachycardia, you have to look at only one thing. You have to see if there is a P wave or there is no P wave. Whenever you have a narrow complex tachycardia, you just have to see for the P wave. If there is a P wave before every QRS complex, that is a sinus tachycardia. If there is a P wave before every QRS complex, it is called as sinus tachycardia. Anything less than 120 milliseconds is narrow complex tachycardia. In this scenario here, are you able to visualize the P waves? This is a T wave. This is not a P wave. Please do not confuse a T wave with a P wave. See, you have to look at the QRS duration and you have to see how many large boxes it is or how many small boxes it is. We discussed it, right? One small box would be 40 milliseconds. So if it as big as 3 small boxes, then it is 120 milliseconds. So here it is less than one small box. You can fit 5 of such QRS in one large box. That's how you determine it is a wide complex or a narrow complex QRS interval. There is no P waves which are visible in this EKG. On an EKG, if you find narrow complex tachycardia, you have to see for the P waves. If the P waves are absent, that means it is a supraventricular tachycardia. Nehru Nagar, what you did not understand? If you the doubt is the QRS interval, see, you have to zoom in for this. If you can now see the small boxes, if you cannot see the small boxes, it is as one small box, and that is how you come to know that this is a narrow complex tachycardia. T waves never disappear on an EKG. T waves never disappear on an EKG. You cannot have a cardiac contraction if there is no repolarization. If you're seeing only one wave, that is a T wave. And if you really want to see when the P waves are visible, this is where the P waves are. This is called as a retrograde P wave. The P waves are here. This is where you have the P wave. It is hidden in the QRS complex. This area. The one where the hand is holding it. Are you clear with the instructions for now? The P waves, you find the P waves, and if you don't find the P waves, all right. In case of a supraventricular tachycardia, the excess rhythm of the ventricle is generated because of the accessory pathway. What that means is, before a sinus node can activate the ventricles, this accessory pathway keeps on activating the ventricles again and again. So there is here you're having your accessory pathway. This accessory pathway keeps on activating again and again. It will keep on forming a loop. This will keep on activating the ventricles. That's why when the P waves contract here, it is irrelevant to the ventricle, because the ventricle is activated by the accessory pathway. The accessory pathway, it keeps on roaming around in that circuit. If the P waves are absent, it is supraventricular tachycardia. The way you can stop this circuit, one component of this circuit is the AV node. As I said, that the P wave is not, the SA node is no longer involved. It is the circuit that is going on. The circuit is formed by the accessory pathway and the AV node. If you stop the AV node, the circuit will break and the sinus rhythm would be restored. If you break the circuit, the sinus rhythm will be restored. To break the circuit, you provide AV nodal blocking agents. And the first step is to increase by doing carotid massage. You do carotid massage, it increases the acetylcholine release through a maneuver called as the vagal maneuver. The second step is you give adenosine. Amiodarone is not useful here. You cannot reassure a patient with a heart rate of 150. He's not going to listen to you. I am not going to listen to you if I have a heart rate of 150. IV fluids, not useful. There is no hypotension. Why would you give IV fluids? So, you break the circuit and you give vagal maneuver. First thing. Are you with me or have you given up already? I'm sorry to put you through this torture. I understand this is absolute torture for you. You're using your grey matter like never before. But sir, then all impulses go through AP. All impulses go through AP. It is only when the conditions become so favorable that the AP can keep on activating itself again and again. Kakinada, we did use AV block in atrial fibrillation also, if you remember. What does beta blockers do? What do calcium channel blockers do? They are also AV nodal blocking agents. But there we wanted to block the AV node for a long time. Why is it not the first line, Kakinada? What is first line? Did you go home and read? What is the first line? What is the first thing that we do in atrial fibrillation? No. I have recordings of yesterday's class. How do you reduce tachycardia? How do you control the ventricle? That's why I don't like you guys asking questions on the sides. You don't pay attention. You just keep on asking questions. Oh God. Oh dear God, Kolkata, please. I never said lignocaine in atrial fibrillation. People will sue me. My degree will be taken back. That's why it's good it's recorded. Amiodarone is used for conversion. I told you this. Do you want to protect the atria? Do you want to protect the ventricle? First we have to control the rate. We want to stop the atria from sending in all the impulses. We give the AV blockade. The blockade should be long lasting. In adenosine it has a very short half-life. It has a very short half-life. That's why it cannot be given in atrial fibrillation. Diltiazem, correct. So we give diltiazem, we give beta blockers. You have to go home and read, people. I'm sorry, but you have to go home and read, right? I cannot infuse everything right into your cortex. So we use beta blockers, but there we use beta blockers because it is longer acting. Adenosine is very short acting. It acts for a brief period of time, like a minute or so, or maybe 2 minutes. You cannot give adenosine through this cannula here. You put a cannula right up here, you infuse and you put the arm up. As soon as you infuse adenosine, you put the arm up so that it flows directly to the heart, to the brachial artery, correct? Not the brachial artery, the vein. Sorry, you don't cannulate the artery. You do it in the cephalic vein here. So that's why you cannot use amiodarone in case of atrial fibrillation, because it is so fast and it is for a prolonged period of time. So you cannot just give a drug like that, like adenosine, because it will have no effect. So that's why vagal maneuver is used in supraventricular tachycardia. So narrow complex tachycardias, you have sinus and you have supraventricular tachycardia. I would like, so this is how you manage a case of supraventricular tachycardia. You want to stop the link of AV node and the accessory pathway. So you give the AV nodal blocking agents. First thing, you do a carotid massage. You increase the vagotonic action. Second thing, you give adenosine. Give adenosine. If there is no response, you increase the dose of adenosine. Then you increase the dose again. So it's 6, 12, 12. That is milligram. If there is any confusion regarding the diagnosis, I told you that we are taking at 25 millimeters per second. What we can do is we can increase the rate of the paper to 50 millimeters per second. There is nothing on the previous slide. Please pay attention to what I am teaching, right? You need to focus on what I am trying to teach. You can have the slides and take them home. So if there is some confusion regarding So what we'll do is we will take all your doubts together so that the class has a flow. If you continue this way and I stop and answer all your doubts, it is not possible, because some of you are practically not paying attention, and if that is the case, then we cannot move ahead. See, WPW was a different case scenario. WPW has a different conduction system. In that case, you do not give adenosine because there the conduction is resulting into a ventricular tachycardia. In supraventricular tachycardia, there is no ventricular tachycardia. There is everything, the impulse is going from the atria to the ventricle. See, I am trying to okay. So what we can do is we can skip all of it together and we can go to bradycardia, because I can try to make it more simple, but then all I'll ask you to do is memorize. What you can do is narrow complex, P wave present, sinus, narrow complex, P wave not present, PSVT. What I was talking about, if there is any doubt in the diagnosis, what you do is you increase the paper speed. If you increase the paper speed, what this will do is you were having something like this. Okay? You were having something like this. When you increase the paper speed, you will have something like this. That means, because now every box here was how much? This was 25 millimeters per second. So per second you had 5 large boxes. Now you have 50 millimeters per second. So you have 10 large boxes per second. So now you can see that this is a widened QRS complex. When you have a widened QRS complex, you will be able to locate the hidden P wave. When you find the hidden P wave here, you are able to diagnose a supraventricular tachycardia. That is why in some of the questions it would be mentioned as a double speed EKG was done. Okay, is it clear? So before I move ahead, I would just like to make a doubt clear. When you're talking about PSVT, what we are looking at is SA node, AV node, and an accessory pathway. In PSVT, this pathway gets activated completely. In PSVT, this pathway gets activated completely. That is, this is going on and on and on. Even if this patient has WPW, even if there is WPW, this patient will benefit from a nodal blockade. Nodal block is required in this condition. Okay? If a patient has, this is SA, this is AV node, and this is your the accessory pathway, and the ventricles here are hyperactivated, that is atrial fibrillation. In this condition, in WPW syndrome, nodal blockade is contraindicated. Is this much point clear? Manipal. Okay. So in PSVT, there is overactivation of this circuit. Okay. This circuit comprises of the AP, the accessory pathway, and the atrioventricular node, the AV node. So to stop PSVT, you stop the AV node. Okay. It's like there is a gang of two people. One steals and one carries it forward. So you want to stop that gang, you stop one of them, that is the AV node. If this is a case of WPW syndrome also, in that case you can give adenosine if it is PSVT. Clear? Okay. But if this patient develops an atrial rhythm which can go into the ventricle, like a atrial fibrillation. In fibrillation, this is not the circuit that is activated. In fibrillation, it is the ventricle muscles that is activated. In that condition, it has to, in that condition, you don't want all this excess activation to go down the accessory pathway. And hence, in this condition, nodal blockade is contraindicated in WPW syndrome. Here, you will not give beta blocker or diltiazem. Something is wrong with this. Diltiazem. Okay. That is the only thing you need to remember. In WPW syndrome with atrial fibrillation, all nodal blocking drugs are contraindicated. In PSVT, be it WPW, be it no WPW, nodal blocking drugs are the drug of choice. Just note down these 2 points and you will be able to solve all your answers, all your questions. Now look at this ECG here. What is the axis and what is the rate, and can you identify the rhythm? Okay, what is the rate? This is a tachycardia. Can you notice that this is a narrow complex tachycardia? What I want you to search for is the P and the T waves. Can you see that? No problem if you can't see the boxes. Can you see the P and the T waves? This, can you see the two knobs, the two notches? See, there are P waves. This is the P wave. This and this. So the second point is the P wave. This that goes here. This is the T. This is the P. T and P. So this is a classical example of a sinus tachycardia. Look here. This is an example of sinus tachycardia. That is, there is a P wave and then there is a QRS and then there is a T wave. Is it clear? Okay. Now we'll look at the question stem, how the question was asked. A 32-year-old female comes to you with intermittent palpitations. It is associated with diaphoresis and chest discomfort. She has a past history of generalized anxiety disorder, but discontinued therapy on remission and is currently receiving no medications. Okay, so this patient has a past history of generalized anxiety disorder, which is non-compliant to therapy, no treatment at present. That means this is a secondary tachycardia. That is, there is a reason that she is anxious. Her present heart rate is 120. So these are the clinical clues that would be present in your question when they want you to answer it as sinus tachycardia. So the question is simple. What is the diagnosis? Atrial flutter, we discussed it yesterday. 2:3 block, 3:4 block, and all of those things. This is not flutter. It is not fibrillation, because we know fibrillation will have multiple P waves. at multiple places, and then it will have the QRS and then multiple P waves. AVRT, AVNRT, no P waves. So your answer is sinus tachycardia. So the point about being secondary and primary is when you have a patient presenting to you with palpitations, do you want to look at his heart or do you want to look in his systems? Alright. So this is what it means by primary and secondary. Just like when you say hypertension, you call someone to have essential hypertension when you have nothing to look at. Like this is a blood vessel problem, this is a heart problem. But if it is due to the kidneys, then what is it called? Secondary hypertension. Secondary to the kidneys. That means don't look at his heart, don't look at his blood vessels, look at his kidneys. When you have sinus tachycardia, you have to treat generalized anxiety disorder. That means you have to refer him to the psychiatrist, not to the cardiologist. That is what the basic point is. So certain clinical clues that would be asked is, one is use of caffeine. A lot of caffeine related questions are frequently asked. The reason being it is a commonly used substance. The question stem would be a young patient, a young guy who just joined college is very anxious about going to the college. And now he has his exams coming up, so on and so forth. His exams are coming up, so he has to give, so he drinks 5 cups of coffee in a day, does not sleep well at night. What is the cause of his tachycardia? And you're getting it. So this is how you will diagnose, this is generalized anxiety or this is just drug-induced tachycardia. Is it clear? Okay. So we're finally moving from the complicated tachycardias to the simpler, much simpler bradycardias. Bradycardias are simple. So the only difficulty that you face while evaluating a heart rhythm is differentiating types of tachycardias. So just make a note of it. Whenever you see wide complex tachycardia, try always to remember ventricular tachycardia. Always try and think if this is ventricular tachycardia. If it is not, there are very few options causing wide complex tachycardia. If it is a narrow complex tachycardia and you are not sure if this is a P wave or a T wave throughout the picture and the patient is very symptomatic, there are no clinical clues to suggest that this patient might be having an underlying etiology resulting in this problem, always think of a supraventricular tachycardia. Think of a supraventricular tachycardia. When you have, in the question stem, if you have a condition which does not directly result to tachycardia, then you can think of a supraventricular tachycardia. That is all the point I was trying to make. Now we are trying to go to our next question. The next relation, do you want me to refresh? What is the diagnosis in this condition? Left axis deviation. All right, agreed. What is the rate? Complete heart block, bradycardia. More. I want more answers. When you're evaluating a bradycardia, when you are talking about bradycardias, always have there can only be 4 differentials of having a heart block. Okay. It can only be 4 things that can result in a heart block. 4 ways a heart block presents. That is a first degree, 2 types of second degrees, and a third degree heart block. Now, which strip should we first focus upon when you're trying to evaluate rhythms? So the first strip you need to focus upon is the second lead. The second lead. It is called as the rhythm strip. Now look at the rhythm strip. And you have to walk along the rhythm strip to see for an abnormality. Do you see that there are 4 QRS complexes and then there is a gap? Then again there are about 1, 2, 3, 4, 5, 6, 7 QRS complexes without a gap. When I go back, I again have a gap after 3 QRS complexes. Then I have a gap after 1 QRS complex. Can you see this? So this indicates that there is a sporadic conduction of the impulse, that it sometimes gets conducted, sometimes it does not get conducted. First question that you're going to ask yourself is the P followed by a QRS complex? That is the first question you ask yourself whenever you are facing such a question. This is the P wave here, and then you have the QRS. Then again you have the P wave, you have the QRS, you have the T here. Then you have the P, QRS, T. So this is a sinus rhythm. P, Q, R, S, T. This is a sinus rhythm. When you say it is a sinus rhythm, it cannot be a complete heart block. Cannot be a complete heart block. Complete heart block means that the ventricles are contracting on its own and the atria are contracting on its own. That means there is no conduction of the impulse from the atria to the ventricle. Is it clear? How we ruled out complete heart block? Okay. So the first, where is the block generated? When you have the AV, the SA, the AV, and then you have the bundle of hairs and the conduction system, this conduction occurs here. If my SA node is not working, then there would be no P wave. SA node results in P wave. AV node results in the PR interval. Right? When you call it a first degree heart block, that means the impulse started from the SA node is getting delayed while reaching the ventricles. That is called as a first degree heart block. So first degree heart block is prolonged PR intervals. Prolonged PR interval is a first degree heart block. That means the AV node is at defect here. And how much is the normal PR interval? It should be less than how much? It should be less than 200 milliseconds, 0.2 seconds. Anything more than that would be a first degree heart block. So what would be a second degree heart block? A second degree heart block is when, so see, there is the difference. One is, this is slowing the conduction. In first degree heart block, I need one more slide. In first degree heart block, there is slowing of AV node. Okay. In third degree heart block, no conduction through AV node, right? In first degree heart block, the PR is prolonged. That means it is prolonged. It is delayed, but it is reaching. In third degree heart block, PR has no relevance. P is contracting on its own and the ventricles are contracting on its own. So what would be a second degree heart block? A second degree heart block is, it sometimes prolongs and sometimes it stops. Did you get it? First degree is slows. Third degree is stops. Second degree will be somewhere in between. Very simple. Simplest to understand. So second degree has, sometimes it will stop. Like it will not stop all the impulses, but it will stop some of the impulses. Yes, not conducted to the ventricles. That is exactly what is being spoken about. So second degree is of two types. Second degree is of two types. The first type of second degree heart block, which is called as the Mobitz type 1. Mobitz type 1 is like first more than like third. See, this is simplified Mobitz conduction. What is happening is, in Mobitz type 1, there would be prolongation of PR interval. Followed by complete stop in one beat. And then it will start again. What was happening in type 1 heart block? It was prolonged PR. What happens in Mobitz type 1? It is prolonging PR. It keeps on prolonging and at a point it stops conducting. So it is not like 1 and not like 3. So it is 2. What happens over a period of time is Mobitz type 2 block. In Mobitz type 2 block, the PR is constant, but it will stop some conduction. So it is more like third degree, less like first degree heart block. Is it clear? So PR interval is constant, but suddenly it will not conduct a particular beat. In Mobitz type 1, the PR interval will keep on increasing. That is, first it would be this much PR interval, then the PR interval will be this much, then the PR interval will be this much, and then there would be no QRS complex. So what you're talking about in Mobitz 1, it is the PR prolongation. The characteristic PR being prolonged with each beat is the characteristic of the Mobitz type 1. And Mobitz type 1 is also called as, someone had mentioned it, Wenke back phenomena. Can two beats be missed in Mobitz type 1? Theoretically speaking, no. Because after one beat is missed, the next PR would be a normal PR. Are you clear? Are we with this? Are we together in this? Wencky-Back phenomena is just another name for Mobitz type 1. It is the same. Now with this knowledge, look at this EKG. Look at these EKGs. Look at the rhythm strip. If you are confused ever in your exam that is it a prolonged PR or a not prolonged PR, always look at only two PR intervals for a Mobitz type 1 versus Mobitz type 2 block. First look at the PR interval which is just before there was a mixed beat. Just look at the PR interval. See, this is the missed beat. This is where the missed beat. Just look at the PR interval here and look at the PR interval after the missed beat. Okay. This is Mobitz type 2. The PR intervals are same. The PR intervals are constant. I hope this is clear. Because when you're saying the PRs are going to be prolonged, it might not be very dramatically prolonged. It is, you have to have a sense, a judgment about them. And this is how you'll get that judgment about it. Are we clear? Okay. I think there's some ये स्क्रीन नहीं हिल रहा है ना PowerPoint. हाँ हो गया. कीप कर दो. चलो हो गया. So if you are not finding a particular P wave, you have to go, you have to take a general sense. It may be the P waves are not represented well in one of the leads. I just refreshed. So it may be it is not present in one of the leads. So to call it a third degree hard block, everything should be discordant. It is not one particular beat that you are watching out for. Which strip are you talking about? But all other strips have so many P waves. Why are you finding strip 2? What looks disorganized about this? There is a P wave, there is a QRS, and there is a T wave. Further right. Are you talking about this one particular place where there is no P wave? But you have P waves all across the EKG. Why do you bother about one particular wave? So if the whole EKG has P waves and one EKG strip does not have a P wave, would you count that one P wave because you answered complete heart block? Interesting. What are these waves then? What is this visible here? What about so many P waves which are visible here? Please don't waste my time and everyone else's. What about so many other P waves that are present? Kolkata. What about the other P waves which are present? Why are we having the discussion? How would a idioventricular rhythm be? Okay, we'll get to that sometime. We'll get to it. Hyderabad. There are questions which are doubts and there are questions which are just questions. I would only entertain the former from now on. Look at this strip. When you look at this P wave here, and look at this PR interval here. Can you see the increase in PR interval between the two rings? And can you see after that it is followed by a empty block? So the way I said, the best way is you see this one and then you compare it with the immediate next one and you see that there is a prolongation. So this is a Mobitz type 1 block. Okay. This is what is meant by a type 2 block. That is a dropped QRS complexes. So the PR waves, because this is created. See, an EKG can be created on the computer where it would be perfect. Human body will not be perfect. It will have some P waves lost somewhere. This is created on the computer. This is the perfect image for people who were looking for it. This is how it is supposed to be theoretically. So now we'll be coming to the concept of a premature contraction. So we have covered a lot of topics starting in the last 1.5 or so hours in a period of 2. So which was tachycardias. I am not stating that it would be absolutely clear, but I think I got you started and hopefully it's on the right track. Then we spoke about bradycardias. And the third thing that we need to discuss is something called as a premature contraction. These are the 3 things on a ECG which you have to diagnose for your step exams. Everything else like an acute MI on the ECG, they do not expect you to localize it. Nobody expects you to localize it. Nobody expects you to diagnose pericardial effusion on an EKG. All those things you can go to them gradually, but for your step 1, this is the basic amount of EKG that is required. The very basic, the tachycardias, the ventricular tachycardia versus supraventricular tachycardia, this is all that is considered to be necessary. What you mean by a premature contraction is a contraction which starts before the sinus node reached it. So before the sinus node is coming, there is one ectopic source of activity which is throwing that impulse. This can be in the atria, this can be in the ventricle. So when you have the heart like this, you have it like this, you have the atria and you have the SA node here. There can be an atrial ectopic coming here, or it can be a ventricular ectopic going like that. Whenever you have an atrial ectopic, how would it go? It will go and hit somewhere along the conduction system because the atria is so small. The ventricles will ultimately get the impulse from the conduction system only. Will get the impulse from the conduction system only. So an atrial contraction, in atrial premature contraction is always narrow complex. And a ventricular premature complex is always wide complex. When you're talking about an idioventricular rhythm, that is, it looks just like a ventricular premature complex. An idioventricular rhythm is something similar to what would be seen in a complete heart block. Why you call it idioventricular rhythm is because the heart is now having the atria to support it. The atrial premature contraction will always be narrow because the ventricles are contracting through the conduction system. The ventricular premature contraction would be wide because this is going through the musculature and not through the conduction system. Is it clear? Now look at this EKG. I want you to trace the premature contraction beat. Can you look at this beat here and this beat here and compare it with the preceding beat? This is a normal beat and this is the ventricular premature contraction. When the ventricle throws out an impulse, this is how it will look like. It would be disorganized and it would be wide complex tachycardia. Is it clear? Okay. Just give this EKG a look. I said in the previous one, that we compared the two QRS complexes because this is such a wide QRS complex and this is a normal QRS complex. This is a premature ventricular contraction. Okay. Look at this EKG. Notice the difference between the alternating QRS complexes. This is a classical example of a narrow complex versus a wide complex QRS. This is, when you notice here, you have a normal QRS complex which has a P and then has a QRS complex, followed by a T here, followed by a large complex here, and which is followed by something called as a compensatory pause. Excuse me. It is followed by something called as a compensatory pause. So this particular rhythm, where there is a normal followed by a ventricular premature complex, followed by a normal and a ventricular complex, this is called as ventricular bigeminy. This particular condition is called a ventricular bigeminy. If there is an ectopic beat following every heartbeat, it is called as a bigeminy. If there is one ectopic beat following every 2 heartbeats, it is called as a trigeminy. And if it is after every 3 beats, it is called as a quadrigeminy. Not very important to remember, but this is how it is named. So we'll move on to our final question for EKG. So that, are you clear with the ectopics, the ventricular ectopics, how they look and how they are morphologically differentiated? Atrial ectopics will look just like the normal QRS complex, but there would be a compensatory pause following that. Is it clear? I've got no responses as of now. Should I move ahead? Should I repeat it? Okay. So next question, that is our last question. It is a stem of 3 questions. We want to know what is the diagnosis. The question is, a 72-year-old female comes to the clinic due to intermittent episodes of lightheadedness and fatigue since the last 1 month. She has history of coronary artery disease and underwent CABG for the same. Over the last few days, she has experienced angina at rest. Her medications include aspirin, rosuvastatin and hydrochlorothiazide. What is the diagnosis on the basis of this EKG? What is your diagnosis on the basis of this EKG? Do you see the heart rate? So this is extreme bradycardia. It is very severe bradycardia in this patient. She has almost 10 to 15 boxes between each beat. She has like 5 to 10 beats. This is what an idioventricular rhythm would look like. This is a wide complex tachycardia. A wide complex beat. What is happening? This is a wide complex QRS. These are P, 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 P. Then there's one more P here, P, 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 and P. When you look at it now, it would be much more visible. There are small deflections, which is the P wave, but it is not followed by any QRS complex. Such a condition is a complete heart block. You can see here you have your P wave here, then here, there's some activity here also, and this is a wide QRS complex. It is almost one large box. So this is a characteristic complete heart block. Is it clear? There was a lot of confusion about complete heart block. A lot of places it was answered. This is how it looks like. You know how ventricular trigem, how Mobitz type 1 will look. You know how Mobitz type 2 would look. You just saw bigemini, you saw trigemini. Trigemini was every third beat, so this is not trigemini. And first degree heart block is only prolongation of the PR, which you already know. So this is a complete heart block. When you have complete heart block, that means the SA node and the AV node, it's either they are not able to conduct at all, okay, or they are not functioning at all. It can be in both conditions. Not functioning at all or cannot conduct at all. In either case, you need to have a new pacemaker. You need a new pacemaker. That is, you need a new electricity generator. So we insert a pacemaker. A pacemaker is placed from the outside. The leads are placed on the heart. Such it will go and be placed on the right ventricle or the left ventricle, whatever, and it will generate the pace. So the treatment of complete heart block would be just a new pacemaker. So you have to put a pacemaker. So first thing, you will put a temporary pacemaker. Maybe the heart block is a reversible thing. It happened because of some etiology hitting the heart right now, which can be tied over with time. And you just put a temporary pacemaker. If there is a response, you can remove the temporary pacemaker. But if there is no response, you can just put it on you can place it as a permanent pacemaker. So the pacemaker can be placed anywhere. What is the primary criteria which drives the heart? It is the rate, and the pacemaker will generate its own rate. You can put it as at the right ventricle, you can put it at the left ventricle, you can put it at the SA node. It is of different types. It is a whole new topic of its own. But what you need to know is pacemaker is the treatment of choice for complete heart block. Will have the same level, I believe, right? So this is not necessary. You can place it on the ventricle itself and just pump the ventricle. It does not matter. Is it clear up to now? Yeah, it should have higher velocity than the AV node, than the SA node. What should be the next investigation for the suspected diagnosis? For complete heart block, what should be the next line of investigation? See, when you say shift to the catheterization lab, it is to put in a pacemaker. But that should follow up after some baseline investigations. Hemogram has no impact on your heart rate. Anemia, thrombocytopenia will not have an impact on will not result in complete heart block. So it is not required. Electrolytes are very, very crucial. Potassium in particular can result in a variety of heart blocks. It can cause first degree heart block resulting up to a third degree heart block. So from a first degree heart block to a third degree heart block can be caused by hypokalemia. Also, this patient is already receiving hydrochlorothiazide. So she will lose potassium and develop hypokalemia. So evaluating the electrolytes becomes very crucial. Urine toxicology would become useful if we are suspecting of a drug resulting in complete heart block. Any such drug used in elderly which can result in complete heart block? Digoxin. Whenever you have any cardiac arrhythmia, think of digoxin. Digoxin is an AV nodal blocking agent and it is notoriously known to cause all kinds of heart block. So if you are suspecting that this patient has a complete heart block because of some drug use, you can do a urine toxicology levels. You can also assess for a serum drug levels for the same reason. So if a patient presents to you intoxicated with something, you'll do a urine toxicology level. If the patient is chronically a digoxin user, you will use a serum drug level to assess for the digoxin in the blood. So digoxin is associated with all types of arrhythmias. So amiodarone results in bradycardia. It can rarely cause complete heart block, but it usually causes bradycardia. So yes, it can cause, but it is not one of the most common causes of complete heart block. So these are the causes of complete heart block that you need to know. Coronary artery disease, dyselectrolemia, AV nodal blocking agents, pain and deep sleep. And the first principle of treating complete heart block would be rule out the reversible causes. I never said that their velocity should be higher or lower than any SA node. That was a question that was asked. Since heart block are due to AV node dysfunction, then why pacemaker should have velocity greater than SA node? I was never of that was none of in my slides or anywhere. You asked the question about velocity. When you're setting the velocity, when you're setting up the heart block, those are different concepts altogether. When you're saying that you have to keep a velocity, that just means that if you want the whole heart to contract with a single beat, that should have a higher velocity. What that means is the atria, if you want the atria to keep contracting on its own, you can keep a rate less than the atria. Then the atria will contract on its own and the ventricle will contract on its own. But when you are pacing the ventricles and you want the atria to be paced by that same rhythm, then you have to pace it at a higher velocity than the atria. Is this point clear? So in complete heart block, you have to rule out the reversible causes first. And finally, the simplest question, I believe. Deep sleep has found to have sympathomimetic properties and vagomimetic properties, and that's how it can lead to complete heart block. That's the answer. That's temporary pacemaker is your drug of choice for complete heart block. So you first go from temporary and then you move into the permanent. So this is just to reiterate, you have to see any tachycardias because I thought that is the only place you might not be very well convinced. I am not very well convinced you understood it. The thing is, go back and read it. Stable, unstable, that's an easy answer. Treat if unstable immediately. Regular, irregular, if irregular, tachycardias, It can be atrial fibrillation, can be ectopics, can be all multifocal atrial tachycardia, but that is not necessary. If regular, it can be sinus. If regular and narrow, it can be sinus, it can be flutter, and it can be PSVT. To answer this, you have to ask, is the P wave present? This has a P wave, this has multiple P waves, and this has no P wave. Prodrome is just to have a secondary, like a sinus tachycardia. If it is present, it is most likely in sinus tachycardia. So there is a book called as ECG Made Easy. It's a very small book of 100 page or 200 pages, but it is this big, and you can use this. It's a foreign author, I don't exactly remember who. So you can use this book for referencing. And yes, sure, break is your birthright. So we will give you a break. How long do you want a break? So it is 7:10 right now. Let's meet in 15 minutes. Okay, let's meet in 15 minutes. We'll be starting with heart sounds next. Okay. There would be, but I don't have it. Okay. Time for a break. So the next topic we'll be discussing now is heart sounds. It's interesting, it's simpler, and it's a lot more fun understanding and realizing what heart sounds are all about. The way we're going to proceed with heart sounds is what is going to be asked to you in the question. So in the question, there would be a patient, which would be a cartoon of a patient who would be lying there, and maybe you have to keep your stethoscope at various parts of his chest to come up with the answer. What kind of murmur are you hearing, or which valvular condition would you have this heart sound? So that is your stereotypic questionnaire question that is asked in this context. So what we'll do is we'll walk through all the individual heart sounds so that you have a complete understanding of how we can go about it. So we'll get to the book questions in a while. So when you're studying for the STEP exams, you should understand that it is all about pattern recognition. That means that a particular framework would be given, and you have to separate out the unnecessary information and reach directly to what is being asked. The more questions that you solve, the better you become at this. You would be well trained to directly target what is being asked. Not get trapped in trivialities. 25-year-old girl who cycles all along the way around the river has now suddenly fallen down from her cycle. What is the component of collagen? This might be the question. So all those information that was given was of no use to you. So what you were trying to do here, what you were trying to learn from us is how to have a faster grasp of that question. The more clearer your concepts of something is going to be, the faster and more promptly would you respond to it. So the pattern recognition of murmurs, of heart sounds, you should remember the location. Where is this heart sound on the chest wall best heard? What does this sound increase with and what does this sound decrease with? These are the three things that you have to be absolutely sure that you understand. A sound, where is it best heard? When does it increase? And when does it decrease? This is what you need to understand. I hope this is clear. So this is a normal precordium and these are the various auscultation areas. This is valid for your clinics as a doctor and for your exams. This is the aortic area which is on the second intercostal space on the right side. This is the pulmonary area which is on the second left. The third left intercostal space is called as the Erb's area. Erb's is also known as the second aortic area. This is the second aortic area. The T is the tricuspid area. That is the fourth intercostal space. When you have to name all these spaces, as it is just adjacent to the sternum, it is called as the parasternal space. So A is on the right parasternum, P is on the left parasternum. The M here is the apex. This is the apex of the heart. Apex of the heart would be formed by the left ventricle in a normal individual. So that is the mitral area, because the mitral sounds would be best heard here, the tricuspid sounds would be best heard here, aortic, pulmonary, second aortic. This is your auscultation area. So in your questions, you would be asked to take your stethoscope from A to P to E to T to M and maybe sometimes on the carotids also. So how is this sound generated? Basically what you need to understand is it is because of the shutting close of the valve. This shutting close of the valve results in the particular sound. There are other theories to it. Some say it is because of the pressure changes, the sudden changes in pressure that are happening that result in sound generation. Some say it is because of the volume of the blood. So all of this is a theory. Nobody has gone inside and nobody can see sound being generated. But the most acceptable theory is it is because of closure of the valve. So let's start with auscultation. Now you are all beginning on your journey of becoming physicians, be it cardiologist, be it internal medicine, general surgery, gynae, peds, wherever you want to go. If you want to listen to the heart, make a promise to yourself today, be kind to yourself today. First thing you will listen to is the heart sounds S1 and S2. The first thing that you should listen to is the S1 and the S2. Lub dub, lub dub, lub dub. This is the sound you need to auscultate first. Don't be running behind, oh, this murmur seems to be systolic, oh, this murmur seems to be diastolic. Murmur seems to be nothing. You need to diagnose first the heart sounds. The S1, which would be best heard in your apical region, and that is because of the closure of the mitral valves. This closure of the mitral valves will result in the S1. Now atria, when we were talking about atria and ventricle, atria, ventricle, atria is a smaller structure. So both of the atrias close together, the atria, that is the mitral and the tricuspid valves, they close together. So there is no M1, T1. There is only one sound. It is called as S1. As you move from the mitral to the tricuspid area, the sound of the mitral valve closure is loudest on the mitral area, and of the tricuspid valve closure would be loudest on the tricuspid area. So when you are hearing a regurgitant murmur loudest on the apex, it is a mitral regurgitation, and when you are hearing it loudest on the tricuspid region, it is the tricuspid regurgitation. If you are hearing a murmur, if you are hearing, so S1 sound is only M1 and T1. There is no splitting between the first sounds. It is a single sound. So if it is a single sound, you do not hear a M1 and a T1 component. All you hear is a lub, lub, lub. This lub is because of the mitral as well as tricuspid. If it is heard, you're hearing it over the mitral area, you will hear the mitral sound better. If you're keeping it over the tricuspid area, you'll hear the tricuspid sound better. So factors which influence, which increase the S1 sound. You need to remember those. These are memorization based things. Loud S1 and loud S2. Loud S1 would depend upon the position of the mitral valve. That is how close it was or how far away they were. If it is far away, it will come and close by the time the systole is almost complete. If it is close, it will cause a loud dham, dham, dham to it because of the high pressure changes here. If the PR interval is short, then the mitral valves are moving a small distance, because PR short means there is a short diastole. Short PR interval increases the S1 intensity. Mitral valve fibrosis, that is mitral stenosis, results in increased sound intensity. Hyperdynamic circulation is associated with loud S1. So you need to remember this. Mitral stenosis, short PR, short diastole. Short diastole basically means tachycardia. So tachycardia will have loud S1 and hyperdynamic circulation. These are your conditions resulting in loud S1. So the loud S1 would be mitral stenosis. Sometimes in mitral valve prolapse, if there is not a significant component of mitral regurgitation, that is pure mitral valve prolapse will result in loud S1. But if there is associated mitral regurgitation, then it will become a soft S1. ASD will result in a loud S1 because of the high pressure changes that is happening there. Variable S1 would be complete heart block and atrial fibrillation. Can you get a split first heart sound? A split first heart sound means there would be such a considerable time delay between your M1 and your T1. And this is seen in one clinical entity called as Epstein's anomaly. This is a pediatric heart problem. This is a pediatric heart problem which happens because the tricuspid valves are placed lower. That is why it happens in, it is associated with the split S1. It is associated with right bundle branch block. Right bundle branch block results in delayed activation of the right ventricle. If the right ventricle is delayed activated, then the tricuspid valve will close later. And that is how it happens. It results in a splitting of first heart sound. So if you are asked, is there a condition where first heart sound is split, you should remember Epstein's anomaly. Now we'll move to the second heart sound. So the second heart sound would be heard here, and that is at the base of the heart. So this is the base, and that one was the apex, the triangle shaped heart. When you're talking about the second heart sound, it is produced by the aortic and the pulmonary valves. Okay, the aortic is the left, the pulmonary is the right. The left ventricle is the powerful contraction that happens. Is a powerful contraction that is happening place. This powerful contraction is happening against a very powerful pump called the aorta. The aorta is filled with blood and it is a big artery. It is taking in all the blood from the ventricles. Because it is against such a high pressure, the aortic valves close very fast. The aortic pressures are very high. The ventricles tries to generate and pressure and push all the blood inside the aorta. However, because the aortic pressures are so high, their valves shut close faster. So A2 happens earlier. After that, the right ventricle starts to contract. As it contracts and pushes all this blood, the pulmonary arteries are low pressure circuits. They are not as high pressure as the aorta. So there the pressure keeps on rising for a considerable amount of time. only after that does it reach the intensity where it can shut close. That the pulmonary pressure is greater than the right ventricular pressure, and then it can shut close. This happens after a prolonged period of time. Hence, in this condition, the P2 comes later. Is this concept clear? What do you mean TOF? And what do you mean Lee? I didn't understand both the questions, Bangalore and Kota. Yes. Is that due to lithium? Yes. What happens in TOF? I'm not getting it. Why are you asking about TOF? I did not mention TOF anywhere. Anyways, so is this concept clear? All right. So this is how we are always going to think of the aorta and aortic sounds and the pulmonary sounds. When you have, please stop commenting if you don't have a doubt there, or if it is something you can solve it by yourself. It's distracting, and it's distracting for the other students. What do you mean by ASD now? I'll answer questions only after an hour of teaching, okay? You're wasting time of other students. That is why I don't like it. So the determinants of what we are trying to understand here is why the A2 and the P2 sounds are different. What happens is during inspiration, all the excess amount of blood from the thorax goes on the right side. When you inspire, all the excess blood goes into the right side. So inspiration will result in RV inflow. That is, the blood will come into the right sided circulation, the RA and the RV. So see what was happening. Already the ventricles, the pulmonary P2 was prolonged. P2 was happening later. Now there is excess of blood on the right side. So this excess of blood by the thin-walled right ventricle to eject into the pulmonary artery takes even longer period of time. So this longer period of time means that the A2 and this P2 becomes more widened. And this is called splitting. So this is during expiration and this is during inspiration. And this is called as split. So this is the A2 P2 split. So that is how the S1 is a single sound, but the S2 is a dual sound. And the duality of that sound is best heard during inspiration. And when you are trying to hear the splitting of the sound, you're trying to hear for the pulmonary sound, right? You're trying to hear the pulmonary sound, only then can you call it a split. Pulmonary sound will be best heard on the pulmonary area. So that is why the pulmonary area would be where you'll place your stethoscope to hear for the A2P2 splitting sound. Is this clear? So this is how we have the inspiratory and the expiratory components of the A2P2. So how does this sound here like? It's like lub-dub, lub-dub, lub-dub. This is your normal sound. Your lub is your M, your apical sound. It is your mitral and your tricuspid. It is your S1. And say dub is your S2. So it goes lub-dub, lub-dub, lub-dub. And suddenly, when you take a deep inspiration, it becomes lub-dub, 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 lub-dub. This dub is your splitting of your second sound. So it's not like lub-dub, lub, lub-dub, lub. It's not that big a split. It is a fine split. It's lub-dub, lub-dub. And if you want to hear it the best, take a stethoscope, keep it on your left side, keep it on your pulmonary area tonight when you're lying down. Take a deep breath, hold it, then again take a deep breath for some time. You will definitely hear a split in yourself. It is physiologic. So that is what we are talking about. So again, now there would be causes of increased sounds and decreased sounds. When you have to memorize what will increase the sound, just think about pressures. If there is a strong aortic pressure or there is a strong ventricular pressure, there would be a greater pressure difference. Greater the pressure difference, greater should be the sound. So systemic hypertension or coarctation of aorta, which will have aortic hypertension, those conditions, or TOF, TGA, just memorize it by TOF and TGA. TOF and TGA will have increased aortic sounds. TOF will have what? TOF has VSD and overriding aorta. There is pulmonary stenosis. So all the blood goes into the aorta, and this excess of sound will lead to a bum, bum, and that leads to your loud A2. So systemic hypertension, coarctation of aorta, all these findings, this is how you're going to understand it. When you're talking about the pulmonary circulation, it is again the same thing. If it is the pulmonary artery which is hypertensive, this is what it is going to happen. So increased P2 is pulmonary artery hypertension, idiopathic pulmonary dilation, ASD. ASD will have excess of blood going from the left circulation to the right circulation. It is something very similar to the TOF physiology. In TOF physiology, everything is going into the aorta. In ASD, everything is going into the P2. And that's why it's going into the pulmonary. And that's how it will have a loud P2. Now, which conditions do you have a soft A2? Where there is low pressure, that is hypotension, or the valves are not closing at all. And which condition the valves don't close? That's called regurgitation. So regurgitation anywhere in your heart is associated with a soft sound. When the doors don't close, how would it make a loud noise? If the doors don't close, how would it make a loud noise? It cannot make a loud noise and it won't. I hope this point is clear. Again, when you're thinking about decreased P2, again you have regurgitant lesions. When you say severe right ventricular tract obstruction, like pulmonary stenosis, what is happening there? When their walls are not closing together tightly, they are stenosed, they are fibrosed, they just stay like this. So that is why the dhum, 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 this is not happening. So that is why the sound is very low. I hope you are copying this, you have made notes of it. It's not something which is very difficult to understand, but I want you to go back home and revise it. ES will decrease A2, yes. MS is associated with loud S1. That is the only thing that is associated with the loud S1. If you have to have a memory hack. You guys know that every time I go back, my time is with you is limited. I'll be able to teach you less topics. Not my loss, it's your loss. Yeah. So this is how what we were talking about, the inspiratory and the expiratory. So what I want you to do is go to YouTube today. I hope you have catched up on the Game of Thrones thing. So go to YouTube today. Don't watch Game of Thrones flashbacks. Just listen to the splitting of the sound. It will take 1 minute to hear it on YouTube. You'll remember it very well. Just go and listen to the splitting of the sounds. How it is split, so that you know you have developed a model how you need to approach these patients. And yes, you can follow your own respiratory variation. That is always the best. Now, a lot of questions are asked on the splitting. What you need to understand about splitting is when I take a deep inspiration, excess of blood is entering the right atrium. This blood will then enter the right ventricle and this will delay the second heart sound. This will widen the A2P2 gap. Any condition where the second heart sound, that is the closure of the pulmonary valve, is delayed already, will result in a persistent A2P2 gap. What this means is this lub dadap, lub dadap, lub dadap can be heard during inspiration as well as during expiration. So when split is heard in inspiration, expiration, it is called as wide split. Oops. Inspiration and expiration, it's called as wide split. Okay. So supposedly you are hearing someone's heart sounds and you kept it on the pulmonary area. The patient during inspiration and during expiration goes lub dadap, 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 lub dadap. This sound, which I have amusingly created for you, is a wide and variable split. Let us lub dadap, lub dadap, lub dadap, lub dadap. Getting it? The sounds are increasing in duration. The difference is increasing in duration. This is called a wide and variable split. What do you understand by a wide and variable split is that this heart sound that the right atria can accommodate still more blood during inspiration. During inspiration, the heart should take in more blood. When you call it a wide split, that means it is already receiving more blood. So, but during inspiration, it can accommodate, like if it has taken 100 ml, normally it takes 100 ml. Now it is taking 150 ml, but during inspiration, it can accommodate 300 ml. So 150 got the splitting in expiration, and this 300 has resulted in that variable split. So the causes of wide and variable split are severe MR and pulmonary artery hypertension. All these two conditions can result in a variable split. In severe MR, A2 happens early. Here, the second heart sound of the pulmonary is not delayed. It is the A2 which is happening early. Why? Because in severe MR, if it ejects out 100 ml, 60 ml gets regurgitated. So what does the aorta get? 40 ml, and then the aorta shuts close. Down. So it gets shut close because it had only 40 ml to eject out. But the pulmonary is normal, so it will keep ejecting out whatever blood it has. So it would be a wide split. And during inspiration, excess blood can get into the right side, and it would be a wide and a variable split. Are we clear with the wide and the variable splitting? Others, I'm waiting. Okay. So when you have a condition where the right atrium, we said that right atrium normally takes 100 ml, supposedly 100 ml. It was receiving 150 ml and it could go up to 300 ml. Suppose that the right atrium is already receiving 300 ml. If it is already receiving 300 ml, can it receive any more blood? It cannot. So this increase in the right side of the blood, right-sided blood inflow cannot take place. When it cannot take in blood, it is not going to take in blood. End of story. So when it cannot take in the excess of blood, this splitting, this lub dadap, lub dadap, lub dadap, Lubed up. That means it stays lubed up. Whatever you do, it is wide and fixed. Wide and fixed. The classic example of a wide and fixed A2P2 is ASD. See, the left ventricle is a high pressure circuit. Left ventricle is a high pressure circuit. And on the right side, you have the, so the left atria is a high pressure thing. Right atria is a low pressure thing. Low pressure chamber. So when there is a septum connecting these two, from the high pressure, all the blood will be pushed into the right atria. It will be pushed till the time the right atria says, God, I cannot take any more. Keep it with yourself. Till that time, all the blood will keep on moving to the right atrium. Now, inspiratory increase into the blood is not possible because the right atria is already full. It has already taken its 300 its capacity. So this results in a wide and fixed A2P2 sounds. So any left to right shunts, ASD or conditions of right ventricular failure will result in a fixed A2P2 sounds. There is a condition called as reverse split. What is a reverse split is that P2 happens before A2. P2 happens before A2. What could be a condition where the aorta will keep on contracting slowly and steadily? So much so that the pulmonary contraction has ended. One such condition we spoke about when we were seeing EKGs was LBBB. Everything in medicine is interrelated and some concept based. It's not time restricted, but it is concept based. Left bundle branch block, we spoke that it was the septum will now get polarized from right to left. The conduction of the ventricles will happen from right to left, and right to left would be through the musculature. The grand musculature of your left ventricle, which is already 3 times more muscular than your right ventricle. It is going to happen through that. So it would be so slow. It would take so much more time. Your chambers would look like something like that, where your EKG is looking like wide and dilated QRS complexes, something like this. This will happen much after your P2. And this is a classical condition of a reverse split. So when you call a reverse split, first it would be best heard in the aortic area. And it would be best heard during expiration. Because during inspiration, they'll come close to each other. But during expiration, it will stay far away. So a split of sound which is best heard in expiration, not in inspiration, is reverse split. A split of sound which is heard both in inspiration and expiration is a wide split. A split of sound which does not change with deep inspiration or expiration is a fixed split. 3 types of splits. Are you clear? Okay. When you're talking about others, you should remember aortic stenosis is also one such condition which results in massive left ventricular hypertrophy. And the outflow obstruction is such that it will take a lot of time to eject inside the aorta. So because it will take so much time to eject into the aorta, it will also result in a reversed split. So you have a wide fixed split, you can just notice it. The wide variable split is something which is happening normally. A wide split is something which is heard both during inspiration and expiration. A reverse split is something which happens only during expiration. And a wide and fixed split is one which does not change with inspiration or expiration. The conditions causing a single second heart sound. Is it clear, Nehru Nagar? So conditions where there is a single first heart sound. A single second heart sound would be either the aortic component is soft or missed, or the pulmonary component is soft or missed, or both are happening at the same time and the split is lost. Only three, these are the three ways how you can have a single second heart sound. Is it clear? So it may be that the walls are calcified and no longer this dhum, dhum, it's not happening. What is happening is truck, truck, truck. Because the walls are calcified, it is thick walls. So you cannot close it with that intensity. That is happening. Maybe there is an absent P2. It can happen in truncus arteriosus. There is a single ascending artery, or it can be happen in pulmonary atresia. These are all theoretical aspects. You don't need to memorize it for your, you need to, but for your peds. So I'm not concerned there. But you need to memorize it for your peds and your congenital heart problems. The child is born with a single second heart sound. What is it? So it can be either a severe AS, or it can be truncus arteriosus and pulmonary atresia. And condition which you need to remember is this. As a medicine point of view, AS is one of the commonest valvular heart disease, and it is the commonest valvular heart disease in the West. Happens with age, or it is a disease of the old age, that is atherosclerosis of the wall, lead to aortic stenosis. So there you will have a single second heart sound. So single second heart sound can have a reverse split, right? With a reverse split, that means P2 goes behind A2, or you can have a single heart sound. So first it stays like A2 and P2 are different. Then as the aortic pressure starts to mount up, you have A2 which happens with P2. So this becomes a single sound. But then A2 becomes super delayed and then it goes behind P2. And then this becomes a reverse split. This is how aortic stenosis progresses. So what this tells you is, when you are hearing a reverse split, you know that this is severe aortic stenosis. This is not mild aortic stenosis or moderate aortic stenosis. So this examination per se not only tells you the diagnosis, but also helps you stage the condition. So this becomes very important. When you can stage a particular condition just by hearing about it, it becomes very important. Are we clear with the first and the second heart sounds? Do you have any questions regarding that? All right. All right. Okay. So now we'll be moving to the third and the fourth heart sounds. Now, identifying, auscultating the third and the fourth heart sounds is a tricky business. Why? Because it is actually, the heart beats 72 times in a minute. Each cardiac cycle will have an S1 and will have an S2. So the difference between and S1 to S1s is less than 1 second. Most of the patients who will see you, they'll have a tachycardia. They'll go into 100. So at 100 beats per minute, delineating S1 from S2 is a task. Delineating S3 from S4 is next to impossible. But for your questions, S3 and S4 would be mentioned. This patient had S3, this patient had S4. So when it is mentioned, it becomes a mandatory thing to know. When in your cardiac cycle, what happens is, first, you have the chambers. Okay, let's make your chambers. This is your right side and this is your left side. Flow can happen from a high pressure circuit to a low pressure circuit. from a high pressure chamber to a low pressure chamber. When the left atria fill up during diastole, they push out all their blood into the left ventricle. Okay. So if it had 100 ml of blood, it starts flowing into the ventricle. The ventricle is a big muscle. It's a big cavity. Compared to the atria, ventricles are big muscles. So it will have a pressure of its own. And now you're adding pressure by putting it more and more blood. So when this reaches up to say 70 ml, the pressure becomes too much, so that the pressure on both the sides become equal. The left atrial pressure and the left ventricular pressure becomes equal. What does the Mother Nature has helped us? How would we push in the remaining 30 ml? The atria will now contract. And that additional 30 ml of blood will flow into the ventricle. This is the basis of cardiac contractility and heart sounds. The pressure differences. When it is 100 ml, first it can easily go in because the pressure in the ventricle is less. But when the pressure in the ventricle rises, it requires the contraction. Okay. This contraction, this droop of the left atria into the ventricle is the last thing the atria does, right? First there is passive filling and then it contracts in the end. If it contracts in the end, this is the last sound of heart. So S4 is the atrial contraction. That is the final thing the atria can do for her beloved ventricle. Contract and put in the last 20-30 ml of blood. So what is S3? We are talking about S3. What S3 is, when you put in that 70 ml of blood, the ventricle suddenly went up to its maximum capacity. Suddenly it got stretched to its maximum capacity and then it said, bus ho gaya. It said, bus ho gaya. This bus ho gaya is S3. When the ventricles are dilated to its maximum zenith, to its maximum hilt, it stretches and it tries to come back. And this creates a sound which is called as third heart sound. If you don't remember what this is, bus ho gaya. If for the people from Pune and Nagpur, it says bus zala. I cannot say it in any other language. I'm so sorry about that. But it says that's enough. You can say it's the way of ventricle saying that's enough. So that's enough. Bus zala. That's it. Is your S3, and then when the atria forces after that is your S4. I cannot simplify it further, at least till date. So I hope this is clear. Is it clear? Pune and Nagpur, I hope it is clear. Tumchasati. Okay. Alright. What we are trying to assess when you're seeing these things, because there is a component involved here which is called as compliance. There's a understanding of compliance. What do you mean by compliance is how much volume can you take before increasing your pressure. So that is basically delta P upon delta V. That is the amount the pressure changes per change in volume. If you are very compliant to me, whatever I tell you, you will do without putting pressure on me. That is a very compliant ventricle. It keeps on taking whatever blood you give her. If it is a non-compliant ventricle, it will not take the blood very soon. So non-compliant person will stop listening to me very soon. I cannot. He'll put the pressure back to me. In acute cardiac pathologies, the compliance of the heart is always low. In acute cardiac pathologies, because the heart is taut, it is firm, it is the way it should be, it is low. When the compliance of the heart is low, this 70 ml would become a big thing for the heart. When the compliance of the heart is low, this 70 ml becomes a big thing for the heart. So supposedly there is a rupture of the mitral valve resulting in mitral regurgitation, acute mitral regurgitation. So what happens is, this starts to contract blood. This tries to put out this 70 ml, but some of it goes inside the atria, and the atria from 100 becomes 130. And then instead of 70 ml, it tries to push in 100 ml. But the ventricles are non-compliant. It cannot take more than 70 ml. It is meant for 70 ml. And that is why it will produce an S3 sound. That is why it produces an S3 sound. S3 sound tells you that the ventricle is non-compliant. This is the sudden limitation of filling. So acute MR will have S3. Whenever there is S3, S3 would be resulting in acute MR, acute conditions will have S3. S3 is not a sign of pathology. S3 is not a sign of pathology in young adults. In young adults, the heart is compliant, they are running, they are active, sometimes they are drinking too much water or whatever. So it may be heard up to a particular age. In young adults, S3 can be heard. But in elderly, you're hearing S3, that indicates heart failure. That indicates that the left ventricle is overloaded. It is non-compliant. This delta P by delta V is going too much. It is under too much pressure. And that is S3 is acute. So whenever you see that S3 is present, think about heart failure, think about ventricular overload, think about a non-compliant ventricle. This is called as a ventricular gallop, because the ventricles are the ones which are creating the sound. So it is called a ventricular gallop. Now when you talk about S4, with S4, what is happening? When you consider this, when you consider this volume, this was 70 ml. This here it goes 70 ml, right? Supposedly, I am not sure what compliance is, buddy. I am really sorry about the, it is the concept that matters. It may be delta V divided by delta P. I am really sorry about that. I agree to that. I have no idea. I am coming to a topic which is not very well understood. I am trying to help you understand it better. See, the basic difference is, when the ventricle is non-compliant, okay, every blood that goes inside the ventricle will lead to stretching. Alright? Every blood that goes inside the ventricle will lead to stretching. But when the ventricles are refusing to take any amount of blood more, when the ventricles are refusing to take any amount of blood more, then the atria has to force all the blood inside the ventricle. Did you get this point? Delta V by delta P. Okay. Change in volume by change in pressure. Now what I'm saying is, I said the non-compliant heart led to S3. non-compliant heart led to S3. Okay. Non-compliant heart will also result in S4. And this is the core concept I want to put across, that compliant heart is different. Non-compliant heart will have an S3 and will have an S4. Listen, when you have the ventricle which is not taking any more blood, it has stretched and it refuses to take any more blood. When it stretched, it produced S3. But the atria are still having a lot of blood. Because of the acute MR, the atria have a lot of blood. It was supposed to have 30 ml, right? Now it has 60 ml because of the regurgitation. And this atria will contract forcefully, force feeding the ventricle with the excess amount of blood. This force feeding of the ventricle will result in the S4. Are we clear about this? So amongst S3 and S4, which one would be present more in a non-compliant heart? S3 and S4. S3 would, in a non-compliant heart, S3 and S4. S4 is forced going into it, so it produces more sound. So S4 would be louder. I'll just explain this point again. When you have the ventricles, there are two types of ventricles. This is a normal ventricle which has 100 ml. 70 goes passively and 30 goes in actively. Okay. This produces this atrial contraction. 30 ml will lead to S4 and at 70 ml will lead to S3. Normal, like supposedly this is the maximum capacity. Suddenly the mitral valves have stopped functioning. So the atria now has 150 ml. Okay. Passively, because the compliance of the heart has not improved. Non-compliant. Non-compliant heart. Passively, it could give out how much? 70 ml. So 70 ml went inside. And at 70 ml, you got your S3, your third heart sound. Clear? At 70 ml, it is maximum stretch and it produces the third heart sound. But how much volume is still pending inside the atria? 80 ml of blood. Ventricles are not going to take a single ml passively inside. So the passive filling is again 70. But the active filling, which is your S3 sound, active filling will be 80 ml. So that would be a dhudum that goes inside the ventricles. And this is your S4, which is active. Louder. Right? So whenever you are asked between S3 and S4, which is the sound which you will get in a non-compliant heart, it is said S4. Clear? This concept should be clear. Like, it is not that S3 is going to disappear anywhere. S3 is also going to be there, but S4 is going to be louder than S3. That's why we are discussing the non-compliant heart. Now we'll see the compliant heart. When you're talking about the compliant heart, which is called the bade dil wala, that is The atria has 150 ml. Atria has 150 ml. Atria will take in, now the ventricles have become super compliant. They are ready to take passively a lot of blood. So passively, it will take in 120 ml of blood because it is compliant now. The delta V by delta P, it will take in more blood. And so this is your passive, and at 120 you will get your S3. But your S4 will only be 30 ml. Will only be 30 ml, which is your active. So here S3 would be much louder than your S4. So S3 is heard. S3 is better heard, or S3 is heard. Is this concept clear? Great. So when you're talking about a compliant heart, which sound should be heard? Correct. It is the third heart sound. So in chronic MR, there would be dilatation of the left ventricle, concentric hypertrophy, eccentric hypertrophy. Eccentric hypertrophy से क्या होगा? Compliance will increase. So that eccentric hypertrophy results in an S3 sound. In acute MR, there is no hypertrophy. The delta P, V upon delta P is very high or very low. The compliance is very low. So that means acute MR will have an S4. Now, because you have been trained here, you are listening to it, you should remember that S3 is not going to disappear anywhere. But S4 is going to be louder. So we say it as S4 gallop. And here we say it as S3 gallop. Samjha? Clear? I'll answer that question. Okay. Now, look at various scenarios where you can have such a thing. First thing is chronic heart failure. Chronic heart failure. What happens in chronic heart failure? The cardiac contractility is not good, right? Cardiac output is decreased. So do the kidneys get blood? No, they don't. So the renal blood supply is decreased. What does the kidney secrete? Kidney starts RONA, it secretes RAS. What does the RAS do ultimately? It causes volume overload. So this is a chronic condition. Chronic condition leading to chronic volume overload. It is not happening overnight. Today, tomorrow, 1 week, 1 month, 6 months, and there is volume overload. Chronic overload. So with increasing volume would increase the compliance. So would increase the compliance. In a compliant heart with excess volume, what kind of sound does it result in? It results in the third heart sound. This is why you will have a third heart sound. And this third heart sound will be called as a ventricular gallop. On the contrary, a patient presents to you with sudden myocardial ischemia. Sudden MI. The ventricle is suddenly not pumping out blood. It was supposed to pump out also, right? It cannot just take in, it has to pump out. So the ventricular output suddenly crashed. Ventricle is not taking any more blood. It is a non-compliant heart. So the 100 ml of blood that we wanted to transfer from the atria to the ventricle, this 100 ml of blood now passively goes in only 30 ml. At 30 ml it is stretched, pock, it causes the S3 sound. What will happen to this 70 ml of blood? It requires the forceful contraction of the atria, and that will result in your fourth heart sound, and that will be a bum. That is your fourth heart sound. So your question will say patient presenting to you with acute MI and a atrial gallop. And a atrial gallop sound. That is how you're getting the ventricular gallop and the atrial gallop. Is it clear? Because a lot of your cardiology questions throughout your life will have gallop, 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 heart sounds, S1 heard, S2 heard, S3 heard. Now, why is it called a gallop rhythm? The guy who heard it thought it's like a horse galloping. Every heart failure in this world, any and every heart failure in this world should have what? Should have tachycardia. Any heart failure in this world, just neglect all this for 5 minutes. Every heart failure in this world should have tachycardia. Cardiac output is equal to stroke volume into heart rate. If the patient is having heart failure, stroke volume is very low. To maintain the cardiac output, you require heart rate. So heart rate is increased. Heart rate is 150 per minute. 150 per minute means in half a second there is one heartbeat. In half a second there is one heartbeat. And if you say that in acute heart failure there is S4, that would mean in half a second there are 3 sounds. So that would sound like tabrak, 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 tabrak. That is why it is called a gallop rhythm. Okay, that is why it is called a gallop rhythm, because there is tachycardia and there are 3 heart sounds you need to listen to. So it is a tabrak, tabrak, tabrak rhythm, and that tabrak, tabrak is your gallop. Are we clear? Are we good till now? Okay. So why bother? Why is it so important to remember heart sounds? And because for your steps, it is considered that this is a practical question. This cannot be memorized. Like you must be knowing people who are very, very skilled at memorizing things. But memory is not skill. Memory is different. Memory is you remember things. It is a skill of memorizing. That's a different story. But a medical skill is hearing. Only a doctor can hear. Even maybe clerical position people can also memorize. S3 would be seen in acute, S4 would be seen in acute, S3 will be seen in chronic, and all those things. So it is a pragmatic assessment of your skills. No one knows how the USMLE thing is marked. Like every question has a different mark or it has the same mark. No one knows. What is important to know is if there is any differential marking, these questions would be given more marks than your normal questions. Because this requires more setup, it requires a lot of infrastructure, it requires to record, it requires to give you a headphone, it requires to create a scenario. It is not just typing that usually happens. Okay, and it cannot be answered on the basis of rote memorization. So I hope this point is clear. And we move on to different valves. So we have 4 conditions which we need to be very well versed before we can move on to some questions regarding that, very few questions, so that you are in a better position to answer each and every valvular scenario. So I want you guys to always picturize and visualize as we go about and as you go through your medicine journey. A lot of people have asked me which textbooks should I refer to. I would definitely recommend, if you are a second year or a third year medical student. Oh, yeah, I have a clean here. If you are a second year or a third year medical student, go for Harrison. Harrison is time invasive. You have to invest time in it. So time is the only problem with Harrison. Apart from that, everything in Harrison is good. Lot of people come up to me and say that when I was reading Harrison and my room partner was reading Matthews, he knew much more than I did. That is wrong. The difference there is somebody goes to the gym every single day and works out, and somebody takes a steroid injection. In the short run, the person who took a steroid injection would be beefier. But in the long run, the guy who's going to the gym every day is going to have a much healthier body. Concepts are the key to your medicine. If you are conceptually good, if you're a good conceptual medical student, only then would you be a good conceptual resident and a good doctor throughout your life. If I had to go back in time and invest more time into Harrison, I would do that. Not because I ultimately took medicine or I could have taken anything else. Even if I had taken anything else, the sense of understanding how the world works comes when you read Harrison. It does not come if, like, I would tell you that memorize S3 is chronic, S4 is acute, and I make up some stupid mnemonic to help you memorize it. It does not work that way. So Harrison would be number one, Davidson would be number two. If you're in your final year, you're an intern, you can refer to Davidson. For USMLE, there are a lot of books. There is Step Up to Medicine, there are the Kaplan notes. All those things I have personally never read, so I'm not in a position to tell you if they would be very useful. First aid, yes, very important for your step one, very, very crucial. People who memorize and remember their step one well, that is step one first aid well, usually score about 250. This is my personal experience that I've seen. People who have read step one well, the step one or step first aid step one, they get good scores. Rest is your U-World. U-World is more you solve the U-World, the better idea it gives you. You're more prepared for your final day. 2 tips. 1, always sit for an hour. Always one block at a time. That means at least 40 questions. You should develop the habit of having the concentration to do one block at a time, at least. In the exam, you will be doing 7 to 8 blocks, depending on your step 1 and then your CK. So you're doing 7 blocks, that is 7 hours. We required a break after 2 hours today. That would be 7 straight hours. You'll start in the morning at 9 with 1 more hour. You end somewhere about 4 o'clock. So always have a habit of stretching your concentration. Second thing would be always read conceptually. Don't try to say, okay, this is the answer. All right, next question. No. Invest your time in that question. With one question, you can develop 4 to 5 concepts. If you're developing 4 to 5 concepts and you end up solving 1500 questions, it is far better than the person who solved 2300 questions and did not have concepts in it. Because this would multiply. If you have concepts, it will go up to 3000 questions. So always read conceptually. Do not memorize the answers. That has no role. This option, that option. This is not like repeat would be asked in any way. No recalled. I am not teaching you recalled stuff. Nobody is going to tell you recalled stuff because it's not important. And third thing is manage your energy. Stamina is a reality. you need to have a stamina. Stamina is required. First stamina would be workout. You go to the gym, you have some play, badminton, tennis, whatever. Second is lateral. Maybe have a girlfriend, a boyfriend. Parents do well too. You can go watch movies, have a lateral life so that you can disconnect and come to the surface again. Don't just keep on pulling yourself to the time the elastic breaks. Do you have any other related question you want me to answer before I can go on to mitral stenosis related to this, what we are talking about right now? Should I move ahead? Okay. Mitral stenosis. What you mean by mitral stenosis is when you saw this heart structure and you called it the right and the left, this is how it is usually, that the left side is much bigger than the right side. This opening here is now not an opening, it is a hole. This is what is a mitral stenosis. In the simplest sense of word. Have you seen that water pipe we use to flower the garden, to water the gardens? When you place your finger on that water pipe, that is stenosis. And with that, you understand everything about mitral stenosis. If you completely stop that pipe's orifice opening, there would be a dilation of that tube. I hope you understand what I'm trying to say. This water pipe, which you use to water the plants. If you keep a finger here, you close it, this would become a fast jet into the remaining place. If you completely keep your finger over this, this will just dilate backwards. This is mitral stenosis. This is the concept of mitral stenosis. Oops, this cannot be raised. Anyways. In mitral stenosis, there would be building up of pressure in the left atria. So the left atria keeps on getting hypertrophied. So the left atria is supplied, yes, it is the last topic. The left atria is supplied by the pulmonary veins. So the pulmonary veins have back pressure. So there is back pressure changes in the pulmonary veins. As a result, there would be resistance to the pulmonary artery. There would be resistance to the pulmonary artery, that is, it is not able to go. So this will result in right ventricular hypertrophy. And eventually the tricuspid and the right atrial hypertrophy. In the whole system, the left ventricle stays normal. So there would be no left ventricular problems in mitral stenosis. The basic problem is the LA pressure is raised. Later on, if there is pulmonary hypertension, there would be a loud P2. Because of this, the pressure here, which we have already seen, the characteristic murmur of mitral stenosis is a mid-diastolic murmur. What I need you to understand is any murmur is produced when there is a flow through that orifice. Whenever there is flow through that defect, there would be a murmur. This flow happens during diastole. We just saw it at length. One would be the passive flow and then would be the atrial contraction flow. But all of it would be the diastole. And hence, this is a diastole and hence this sound would be a diastolic sound. Again, this flow happening during diastole and hence it is a diastolic sound. It happens during mid-diastole and it is classically described as a mid-diastolic rumbling murmur. Where is the mitral valve best auscultated? On the apex, in the fifth intercostal space, and that is where you are going to hear it the best. This sound is best heard on that mitral area. It would be heard throughout. What we are talking about is where should it be best heard. There's a difference between, because in the aortic area you hear more the aortic valve and less the mitral valve. So it is best heard in the mitral area. Opening snap, because the valves are so close to each other, it is basically a hole. Even while opening up, they create a sound. Even while opening up, they create a sound, and this happens somewhere in the late systole. The point where their passive filling starts is where the aortic valves open, the mitral valves open, and this opening is called as the opening snap. Presence of the opening snap tells you that the mitral valves are healthy. When you say healthy, that means they are